So hello friends, welcome back to my channel. Medicine of Anjaran. Today we'll talk about acute appendicitis, right? So what do you mean by appendicitis? So normally we know that appendicitis is nothing but the inflammations of the appendix. Now let's talk some few words about the anatomy and the physiology of the appendix. So appendix, as you know, is the vestigial organ. It's the vestigial organ. That means what? It is not having any kind of the physiological function, right? Now see the appendix, basically it is located where? Okay, see is the extensions from the cecum. So if I just name this, structures over here, we'll get to see this the cecum structure, right? And here we'll get to see the ileum. Get to see the ileum, and it is the ileocecal region, ileocecal valve, for example, we can see of the ileocecal regions. And this is the appendix. This is the appendix. So see the appendix that can be located in the different locations. For example, I am showing over here. See over here the appendix that can be seen within the what retrocecal area, within the what within the posterior iliac regions, within the, you can see over here, and the pelvic regions also. Okay. Now see the most common site, the most common locations rather, you can say, of the appendix. Most common, site, you can say, of appendix, that is here within the retrocecal region. That means in the opposite side of the cecum, right? So retrocecal region. A retrocecal region. And the least common site, that's the pelvic region. That's the least, it will be the posterior iliac region. Terminal ileum, posterior iliac region. And the most dangerous locations of the appendix is actually within the pelvic region. Why it's dangerous location? Because as you know that if it is located on the pelvic region, so the signs and symptoms of the appendix that can be merged up with the abdominal for the other regions. For example, within the pelvic regions, that may be for other regions, for the other diseases, the same types of the signs and symptoms can be found, but that can be overlapped along with the appendix. That's why in these cases, so we just say it in terms of the most dangerous location of the appendix, that will be within the pelvic region. Because in these cases the sign and symptoms let's write it over here. Are not marked. Sometimes that can be merged with other symptoms, are not marked. So what did I say? The dangerous location, that will be the pelvic regions. The signs and symptoms are not marked carefully. Okay, or sometimes you can get to see that overlapping of the other symptom. Okay. So the most common site of the location, that's the retrocecal region. That's over here. There's within the posterior regions also you can to see. There's the least common site and the most dangerous within the pelvic regions. Right. Now, normal length of the appendix. Let's have some more words over the general ideas of the appendix. So the normal length, that is from 2 to 20 centimeter, and the intraluminal capacity. Okay, intraluminal capacity, that is near about 0.1 ml. Intraluminal capacity, that is near about 0.1 ml, the interluminal capacity. Now the thing is over here, as we know, it is the ileocolic artery. It is the ileocolic artery. Let's write it this column. It is the ileocolic artery. and it's the terminal branch of the ileophilic artery. Terminal branch of ileophilic artery. Another name we can say the appendicular artery. The appendicular artery that is finally supplies the blood to the appendicular region. Appendicular artery. Okay. So then that will supply the blood within the appendix regions. Now, what are the regions for what we'll get to see the development of the appendicitis? What are the you can say the etiologies. So the etiology is nothing but the luminal obstruction. So the most common reasons for it for to develop the appendicitis, that is nothing but the luminal obstruction. So why we'll get to see the luminal obstructions? Now the luminal obstruction that can be seen for the different regions. For example, if we get to see the depositions of the fecality over there, for example, some fruit seeds are obstructed over there. For example, some worm eggs are over here. Okay. So for the regions, we'll get to see that luminal obstructions. So let's write it over here. So the regions of the etiology of appendicitis, that is the luminal obstruction. Luminal obstruction. Now, while get to see the luminal obstruction, that means in these portions there will be the obstructions. Okay. Now there are the different regions. So, for example, there is a deposition of the fecality. Or if you get to see the development of the tumor over here, or if we see the worm eggs, sometimes the worm eggs, or the fruit seeds. So whatever the pathophysiology we will going to see over here. See, the main thing is that whenever we are getting to see that luminal obstructions over here, so whenever the luminal obstruction will be here, so definitely, as we know, that the venous drainage that will be dropped. So whenever there will be the venous drainage that will be dropped because of the lymphatic obstructions, for example, the venous drainage that will be dropped. So whenever there will be dropping in the venous drainage, so ultimately the blood supply within the appendicular regions that will be also dropped. So whenever the blood supply in this region that will be dropped, ultimately we get to see that necrosis and further inflammations. So that is nothing but the appendicitis. So these are the four regions that can cause the luminal obstruction. So in these cases, if I say, so here we get to see the venous drainage that will be dropped. As a result, we get to see the blood supply within this region that will be also dropped. Further it will lead to the inflammation. These are the main pathophysiology. So you can see over here, and these are the regions. So that what are the causes for luminal obstruction? We can get to see the fecality, we can get to see the tumor or the worm eggs and the fruit seeds. And some microorganisms, they are also responsible to cause the appendicitis. Now what are those microorganisms? The first one we can say the bacteriotides, followed by the E. coli. So some microorganisms. Here we can name, for example, the bacteriotides, followed by E. coli. So these are the organisms or the microorganisms are responsible to develop the appendicitis. Okay. Now we'll talk about the clinical manifestations and further than the treatment. Okay, so let's talk about step by step. First, we'll talk about the clinical manifestations. For that thing, I'll just draw a little bit portions. Okay. For example, is the umbilical regions. And is the anterior superior liquor. Okay, let's draw more clearly for it. Okay. Now, once we're going to see the development of the appendicitis, for example, over here, and from here within 4 to 5 hours, from here within 4 to 5 hours, the fluids, okay, within 4 to 5 hours, that will start irritating, that will start irritating the parietal peritoneums around the umbilical regions, okay, the parietal peritoneum. Okay, now see what I am saying you, that once we are getting to see the development of the acute appendicitis, at that time we will get to see that the fluid discharge from here, and the fluid that can irritate the parietal peritoneum regions, that is present where around the umbilical regions, and this parietal peritoneum, that is too much pain sensitive, that is too much pain sensitive. So whenever this fluid, for example, this will start, that will start irritating these regions. So as I said, this parietal peritoneum, that is pain sensitive, so we'll get to see the development of the pain, okay, since the pain. And there are also other manifestations, that is known as Mantel's score. What do you mean by Mantel's score? So let's write it first over here, then I'm going for the other points. Okay. Mantel's. So what do you mean by this Mantel's score? That is very important for diagnosis of appendicitis. Okay. Now, as far as the clinical manifestations are concerned, as I said, in the first cases we'll get to see that the fluid, okay, as we are getting to see the development of the acute appendicitis. So whenever there is the acute appendicitis, we'll get to see the fluids in terms of the exudate over here. So this fluid that can irritate the parietal peritoneum around the umbilical regions, and the parietal peritoneum in that regions, that is too much pain sensitive. So once it will be irritated, the patients, that they will feel pain. Okay. Now what are the other, see, first point over here in terms of the Mantel score, we'll get to see the migratory pain. Migratory pain. I'll say in details the Roger sign. What is Roger sign? Roger signs means, for example, the individual has developed the acute appendicitis, okay, on the right side. As you know, the locations of the appendix in the right lower quadrant of the abdominal regions, right? So once you are pressing on the left side, you will feel the pain on the right side. So in the contralateral side, so you are just pushing, okay, you are just pushing your thumb or the hand or whatever you can say on the left lower abdominal regions. The patients will feel the pain on the right lower abdominal regions. This is seen in terms of the acute appendicitis, and this type of the sign is known as Roger sign. Okay, this is very important as far as the exams are concerned. Now, first we'll get to see the migratory pain. Second, we'll get the anorexia. Anorexia means loss of appetite. Third, we'll get to see the nausea, vomiting. Fourth, T stands for tenderness. R stands for rebound tenderness. So I'm writing R tenderness, that is rebound tenderness. E stands for the elevations in the temperature. Elevation in temperature. L stands for leukocytosis. Wait, let's write it over here. Okay. Leukocytosis. And S means shift to left. Shift to left. That means immature WBCs. We'll get to see in appendicitis, we'll get to see the immature WBCs. They will come to fight against the inflammations. Okay, so immature WBCs. So what did I say? The most important thing in terms of appendicitis, that is known as, in terms of the clinical manifestations, we'll get to see the Mantral score. Mantral score. So M stands for the migratory pain. In terms of the Roser sign, I have already explained you. A stands for anorexia, loss of appetite. N stands for nausea, vomiting. T stands for tenderness. R stands for a rebound tenderness. E stands for elevation in temperature. A stands for leukocytosis. S stands for safe to live. That means the immature WBCs will be found over there. So this is known as the Mantral score. And in this score, each point will be given on marks, for example. So I am putting over here for migratory pain, this is on, anorexia on, the nausea, vomiting on, except two things. Every points will be given on marks, for example, that is, you can remember in this way, LT2. So the L means where? L means we'll get to see in terms of the leukocytosis. This will be given 2 marks. Where is T? The elevation in the the tenderness, it will be given 2 marks. Rest of the things will be given on marks. On marks. Okay. On marks also. So how much marks we are getting? 3, 4, 5, 7, 9, 8, 9, 10. So we are getting total 10 marks over here. Okay. Now this score, that will help us to diagnose the conditions. Okay. Now we'll go for the diagnosis. Okay. So let's go for the diagnosis. So these are the clinical manifestations we'll get over here. Okay. This is very important. The Mantral score. Another name for the Mantral score, you can remember. So Mantral score, or you can remember Alabato score. Just remember the Mantral score, that is important. So these are the manifestations we'll get. Now we'll go for the diagnosis. If we get to see the value of the score of Mantral score 9 to 10, so the Mantral score, if it is first on 9 to 10, then we can say easily, yes, it is certain that there is the appendicitis. So yes, there is a certain diagnosis. But if the score is 7 to 8, for example, the Mantral score is 7 to 8, that means highly likelihood, the suspectability will be more. If the score is in between 5 to 6, for these things we have to go for the CECT to confirm the diagnosis. We can suspect, but we are not yet sure that yes, the individual is suffering from appendicitis or not. For these things we are supposed to go for CECT to confirm the diagnosis. And if the score is 1 to 4, for example, that means no chance to develop. So no chance to develop the appendicitis. So these are on the basis of the score we can classify the symptom size and in terms of the diagnosis. Of course, we have to go for ultrasonography, USG. By it we can just also confirm the appendicitis. Okay. Now we'll go for the treatment. Okay. In treatment, basically, first we'll talk about in terms of the non-surgical treatment. After that, we'll talk about the surgical treatment. Okay. Okay. So let's talk about that thing. First, we'll talk about the surgical, non-surgical one. Okay. Before that, let's talk about some risk factors. Okay. Because from here some questions have asked in the previous year. So the risk factor to develop appendicitis. So what are the risk factors that can trigger to develop the appendicitis? So first, if we get to see, as I said, the obstruction over there, here, the obstruction within the lumen. So if we get to see the obstruction, the second one, there's the what, diabetes mellitus present. The third one is immunocompromised individuals, extreme of age. Extreme of age is very important. So it can be seen in less than 5 years or more than 65 years. Basically, the acute appendicitis that is found where in terms of in the second decade. In second decade, it is found appendicitis. If we get to see the pelvic appendix. So if you get to see the pelvic appendix at that time, because if you get to see the locations of the appendix within the pelvic regions, at that time the chances to develop the appendicitis that will be much more. Okay. And the history of previous surgery. So what are the risk factors to develop the appendicitis? So the risk factors to develop the appendicitis, that will be in terms of the obstruction, as I said previously also, in terms of the luminal obstruction, diabetes mellitus, immunocompromised individuals, the extreme of age less than 5 years or more than 65 years, the pelvic appendix, and the history of the previous surgery. Okay, so these are the risk factors to develop the appendicitis. Now we'll go for the management. First, see the non-surgical. If we get to see that there is the presence of the bacterial infections, for example, as I said, the bacteroides or the E. coli, at that time we have to go for the antibiotics, and in these cases we are supposed to use the broad spectrum antibiotics, for example, the ciprofloxacin, norfloxacin, okay, or we can also use the tetracycline as well. Anyway, in terms of the surgical management, if we, as I said in the regions, that if we can get to see the tumor over here, the tumor that is also responsible to cause the appendicitis. So the size, there is the dependence on the basis of the size of the tumor. So size of the tumor, if it is more than 2 centimeter, if it is more than 1 centimeter, or if it is in between 1 to 2 centimeter. So there are the different conditions in terms of the size of the tumors, and for this the approach of the treatment will be also different. So up to 1 centimeter, for example, it's up, if we get to see the size of the tumor up to 1 centimeter, at that time we can go for appendectomy. That means we have to remove the appendix. If the size is more than 2 centimeter, at that time we have to go for, of course, appendectomy. Along with that, a right hemicolonectomy. So I am writing the full form over here: right hemicolonectomy. RAC. So appendectomy plus RAC. Of course, we are supposed to go for this one. And if the size is in between 1 to 2 centimeters, simply you can go for the appendectomy. So what did I say? On the basis of the size of the tumor, we have the treatment will be different. The approach of the treatment will be different. If the size of the tumor is more than 2 centimeter, in these cases, of course, we have to go for the appendectomy plus RAC, right hemicolonectomy. If the size of the tumor is up to 1 centimeter, we are supposed to go for the appendectomy. If the size in between 1 to 2 centimeter, here also we can go for the appendectomy. If the size is more than 2 centimeter, we have to go for the right hemicolonectomy plus appendectomy. Okay, so these are the treatments. On the basis of the treatment, now we'll go for the surgical. That means in terms of the incisions. Okay, so here we use the different kinds of the incisions for just to approach for the appendicitis. So the first one we'll talk about the McBurney's incisions. So how to find out the McBurney's locations? Okay, so first of all we have to find out where is the McBurney's location. Okay, let's erase this part. So McBurney's incision. McBurney's incisions, it is one of the important surgical method for appendectomy. Now, for example, I'm just taking this whole part in terms of the abdomen. Here is the umbilical regions, and here there is the presence of the anterior superior iliac spine. Okay, anterior superior iliac spine, ASIS. I am simply writing ASIS. So, what did I say? That the McBurney's incisions. First of all, we have to find out the McBurney's location. So, if we just draw these 2 points, the umbilical regions, and this is the anterior superior iliac spine. If I just draw this line, and from the umbilical regions 2/3, from the umbilical region 2/3, and from the anterior superior iliac spine from here 1/3, the point where they are meeting with each other, this point is known as McBurney's point. This point is known as McBurney's point. So umbilical regions from here 2/3 plus the anterior superior iliac spine from here will get to 1/3. So these two combinations, they will make the McBurney's point. And here we have to go for the incisions perpendicularly. So this is known as the McBurney's incisions. Okay. So we can go for the operative methods by using the McBurney's incision also. Another name for the McBurney's incision, sometimes the examiner they just change the name of the method. So you can use the MacArthur, yes, MacArthur's incisions. MacArthur incisions, or you can also remember grid incisions. So grid incisions, that is another method by which we can go for the appendectomy. Now the second approach. That is known as Rutherford incisions, and the Rutherford incisions also important. Okay, let's show it over here. Or Rutherford incisions. It is also almost same as the McBurney's incisions, but a little different. Okay. So the second one is the Rutherford incisions. In Rutherford incisions, I'll take again the whole abdominal regions over here, and is the umbilical regions. It's the anterior superior iliac spine. Anterior superior iliac spine. And from here we are drawing the straight line. Drawing the straight line. Again in the same portions, 2/3 from the umbilical regions and 1/3 from the anterior superior iliac spine. So this is the McBurney's point, but in these cases I have to go for extensions of the incisions. So for example, like this, the incisions, now this extension. So I am writing over here extensions, incisions in case of retrosical appendix. Now this method is known as Rutherford incisions. Okay. Of course, here we have to go also muscle splitting. Because whenever you are going for the surgical method, of course we have to cut the muscle and we have to split it. We have to get the muscles. Okay. So this is the second one, is the Rutherford incisions. Here, for example, if you just read the anatomy, you get to see the conjoint tendons. So in these cases, we have to cut the conjoint tendon. Conjoint tendon. And we have to cut the conjoint tendon. Another important one is over here that mid, we have to draw a line from the mid clavicle mid inguinal line, and from that line we can go for the incisions. So that is known as mid clavicular mid inguinal line incisions. Okay. So for example, is the clavicle bone. So in between in the mid of the clavicle, and we have to draw a straight line from the midpoint of the clavicle. We have to draw a straight line up to the mid inguinal line, That means the mid inguinal ligament. Okay, and from that point 2 centimeter below, we have to go for the incisions. So that is known as mid clavicle mid inguinal incisions. So another one, mid clavicle mid inguinal incisions.